Welcome to AG Medicine channel. Today I discuss ectopic pregnancy. So let's start the topic. Ectopic pregnancy contributes significantly to the causes of maternal mortality and morbidity. So what is ectopic pregnancy? Ectopic pregnancy defined as pool. So what is pool? Pool means pregnancy in unknown location. So, in normal pregnancy, implantations occur in intrauterine cavity. This is intrauterine cavity. So, in normal pregnancy, implantations occur this area. But in ectopic pregnancy, implantation cannot occur in intrauterine cavity. It's occur outside of the intrauterine cavity except intrauterine cavity. So, when the pregnancy is occurred in unknown location, that is called ectopic pregnancy. So, in ectopic pregnancy, implantations occur in various sites. So, now I discuss site of implantation. The site of implantation mainly divided in two sites, that is extrauterine and uterine. These extrauterine implantations occur 98.5% and uterine implantations occur 1.5%. Extrauterine implantation most commonly occur in ectopic pregnancy. Extrauterine means outside of the uterus. So, in extrauterine ectopic pregnancy, implantation may occur in tubal, that is 97%. Second, ovarian. So, when implantation occur in ovary, that is called ovarian ectopic pregnancy, and there is chances of ovarian ectopic pregnancy, that is 0.5%. And third, in extrauterine ectopic pregnancy, it can occur in abdomen, that is called abdominal, and there is chances of occurred abdominal ectopic pregnancy, that is 1%. Next, I discuss the uterine ectopic pregnancy. So, when the pregnancy occurred within the uterus except uterine cavity, that is called uterine ectopic pregnancy. And in uterine ectopic pregnancy, there are also various sites of implantation. First, cervical. There is chances of cervical ectopic pregnancy, that is less than 1%. Second, coronal. Third, caesarean. Fourth, angular. Ectopic pregnancy, also called ring of fire or Bagel sign, because in ultrasonography it looks like tubal ring structure with a central hypoechoic hole and thick echogenic rim, and that hole represent gestational sac and rim represent trophoblastic tissue. For that, ectopic pregnancy, also called ring of fire or Bagel signs. First,
Now I discuss the etiology of ectopic pregnancy.
First, history of pelvic inflammatory disease or pelvic inflammatory disease. If the patient has the history of pelvic inflammatory disease or presently mother suffer by pelvic inflammatory disease, there is chances of ectopic pregnancy, because in pelvic inflammatory disease the tubal lumen become narrow, or there is a loss of cilia of lining epithelium and impairment of muscular peristalsis, and for that there is increased chances of tubal ectopic pregnancy. Second, contraception failure. Women using any form of contraception having significantly reduced the chances having ectopic pregnancy. But in selected contraception failure, there is increased incidence of ectopic pregnancy. First, IUD. IUD, it's mainly prevent intrauterine pregnancy effectively, tubal pregnancy to a lesser extent, but ovarian pregnancy not at all. So, using intrauterine device, there is chances of tubal and ovarian ectopic pregnancy. Next, sterilization operation. After sterilization operation, there is chances 15 to 50% chance of having ectopic pregnancy if pregnancy occur. This is due to the sterilization failure. Next, use of progesterone only pill. Use of progesterone only pill increase the chances of tubal pregnancy. Other causes are history of tubal ligation, history of infertility, history of induced abortion, and history of ectopic pregnancy, and also the tubal reconstructive surgery. Next, I discuss the clinical features of ectopic pregnancy. In ectopic pregnancy, there is a classical triad symptoms. First, abdominal pain. Second, amenorrhea. Third, vaginal bleeding. Abdominal pain is most constant features of ectopic pregnancy. It is acute and colicky pain. Pain located at lower abdomen, and it can be unilateral, bilateral, or maybe generalized. Next, amenorrhea. Short period 6 to 8 week. There may be delayed period or history of vaginal spotting. Amenorrhea may be absent even in case of ectopic pregnancy. Third, vaginal bleeding. Vaginal bleeding may be slight or continuous. In vaginal bleeding, expulsions of decidual cast may be occurred. Other symptoms are pelvic pain, pain on site of the body, pain in shoulder, neck, and rectum, upset stomach, and vomiting can also occur. Patient also feel weak, urge to repeated urination. So these all are the signs symptoms of ectopic pregnancy. I think you all are understood. Next, I discuss how to diagnose ectopic pregnancy. If the patients if the patient having symptoms of pregnancy, patient can perform UPT, urine pregnancy test. If UPT test become negative, patient can perform repeatedly UPT test after 1 week. After 1 week, if the UPT test become negative, it means patient is not pregnant. But if UPT test is positive, patient can perform transvaginal ultrasonography. By transvaginal ultrasonography, if gestational sac can be detected in uterine cavity, that indicate intrauterine pregnancy. But uterine cavity is empty. In that case, evaluate adnexia. So, if by transvaginal ultrasonography adnexal mass is detected other side of uterine cavity and live embryo also present, it indicate ectopic pregnancy. But if the adnexal mass is not detected by transvaginal ultrasonography, check the blood beta HCG level, and this blood beta HCG level also checked after 48 hours. If this beta HCG level increase double in 48 hours or 72 hours, it indicate normal pregnancy. If beta HCG level increase less than 60 to 65% and greater than 30 to 35% in 48 hours, it indicate ectopic pregnancy. And if the beta HCG level increase less than 30 to 35% in 48 hours, it indicates miscarriage. But if the beta HCG level increase more greater than double in 48 hours, it indicates molar pregnancy. So I think you all are understood how to detect the ectopic pregnancy. Next, I discuss the last part of ectopic pregnancy, that is management. Management can be performed according to the conditions of ectopic pregnancy. In case of rupture, immediately perform surgical management. In surgical management, salpingectomy, and salpingostomy can be performed. What is salpingectomy? In salpingectomy, one or both fallopian tube are removed. But in salpingostomy, create an opening in fallopian tube to remove blockage or pregnancy. In case of unruptured, if the patient condition is stable, motivated, and beta HCG level less than 5000, fetal cardiac activity absent, sac less than 4 semi, and patient has no contraindication to methotrexate, in that condition, medical management can be performed. So, if the patient is suitable for the methotrexate or medical management, at day 1, methotrexate is given 50 mg per meter square by intramuscularly. After that, in day 5, repeatedly methotrexate is given. Then beta HCG level, then check the beta HCG level. If the beta HCG level optimal decline is occurred between 1 to 5 days, weekly monitoring beta HCG level until beta HCG level less than 25 international unit. But if the beta HCG level suboptimal decline between 1 to 5 days, in day 7, methotrexate can be given repeatedly. After that, check the beta HCG level. After 7 days, if the beta HCG level optimal decline is occurred, then weekly monitoring the beta HCG level until the beta HCG level less than 25 international unit. But if the beta HCG level suboptimal decline, in that case, day 12, again methotrexate is given. After that, if the optimal decline is occurred, in that case, weekly monitoring the beta HCG level until the beta HCG less than 25 international unit. But if the suboptimal decline is occurred, in that case, surgery can be performed. So these are the management of ectopic pregnancy. So today I discuss what is ectopic pregnancy and the risk factor or etiology of ectopic pregnancy, clinical features of ectopic pregnancy, and how to diagnose the ectopic pregnancy, and last, the management of ectopic pregnancy. I think you all are understood about the ectopic pregnancy. So that is for today. Thank you.